Good evening, ladies and gentlemen. The Pharmaceutical Society of Kenya members, the Pharmaceutical Society of Kenya members, the members of the Kenya Pharmaceutical Technologists Association, that is KPA, distinguished guests, welcome to today's evening webinar on antimicrobial stewardship programs, sponsored by USAID Medicine, Technology and Pharmaceutical Services Program. This is our part 2. We had a part 1 last month, and we shall have a part 3 next month. We allow our fellow colleagues, distinguished guests, to join in. We are at current 73 attendees, and as we do that, I'll ask you from your to go into your chat box and just type where are you listening us from, where are you joining this webinar from, kindly. Those joining us, asanteni sana. I've requested you to go to the chat box. Dr. Ruth Nyawera, she is joining from Nakuru. Dr. John Macharia from Nairobi. Dr. Stephen Kimatu from Washington, D.C. Asante Daktari, and all the best in the upcoming elections. Dr. Binal Pabari is Nairobi. Kuna Kananu Kubai from Champala. Dr. Lydia Webuye, asanteni sana. Welcome all distinguished guests. As we let in our fellow colleagues joining, I will request the attendees to kindly tell us where you're joining us from, so that we are able to understand the scope of the geographical region we are able to reach. I can see majority coming from Nairobi. Dr. Stephen Kimani Asanti, Dr. Karemi. We're having Dr. Otinga from Dadaab. Asante sana daktari. Dr. Javin Inda all the way from Turkana. Asante sana. Honorable fellow Dr. Elizabeth Ogaja, as welcome senior respected colleague in the profession from Kabarak University in Nakuru. Asante sana. Dr. Mary Mureithi from Kirinyaga County. Asante and karibu sana. Dr. Eric Mwangi, you're raising your hand. Tell us where you're joining us from, and we'll be glad to have you today evening. Asante, Dr. Aldiambo Agulo from Homa Bay, Dr. Collins Jaguga from Nairobi. Asante. Without further much ado, we begin our webinar tonight. It's on antimicrobial stewardship. I will be your moderator. Mbao Bitao is my name. I'm the communications manager at the Pharmaceutical Society of Kenya. Today we have before we begin, we have a few ground rules and announcements. All participants are muted during the entire course of the webinar. I will request you to please ask questions via the Q&A tab at the bottom of your window. The questions shall be addressed by the panelists later in the program. For PSK members, if not already done so, please subscribe on the PPB portal for today's webinar so that you can get your CPD points. For KPA members and other cadres, the attendance list will be forwarded on request to your officials for the awarding of CPD points. But subscribe the CPD points on your respective regulatory authority bodies portals. Note, the CPD points will be awarded only to paid up members. That is for PSK, yeah? And this webinar shall be recorded and shall be made available hereafter on PSK's YouTube page. Before I go to today's agenda, I will also bring to you information that we are part of the COVID-19 committee in matters healthcare professions, and I will ask all our members if you've heard and you've seen of the psychological support call center that has been set up. It is open to us all, to the pharmacists, to the non-pharmacists. It is open to all healthcare professions. So kindly, if you have an issue touching you, if you feel you're worn out, if you feel you're suffering some burnout, please reach out to the call center. For further information on the call center, you can reach out to me. And without further much ado, we begin with our agenda. 7 p.m. welcoming remarks. After that, we're going to have the 7 to 10 p.m. Dr. Kenneth Irungu is going to take us through. Before I introduce to you our speaker for today, I want to introduce to you our guest and our sponsor for this event. Those who have enabled us have this webinar, and I will introduce to you Dr. Collins Jaguga. I won't say much about him because he's a gentleman of few words, and I will introduce to you. He's a member of the MPSK, works with the USAID MTAPS program, and I will allow him to speak more about himself and speak more about their program, the programs they carry out, before I introduce to you the speaker. Dr. Collins Jaguga, if you are with us, this is your chance to introduce yourself and introduce the organization that you're working with, Dr.
Thank you very much, Dr. Gitao, for your kind words. As mentioned, my name is Collins Jaguga. I work for the USAID MTAPS program. And as Dr. Gitao has said, MTAPS program, we are collaborating with PSK to conduct talks on antimicrobial stewardship with the ultimate aim of preventing and containing antimicrobial resistance in Kenya. The Kenya National Action Plan on Antimicrobial Resistance envisions antimicrobial stewardship being taught to both pre-service and in-service healthcare professionals. So this is the in-service bit of it. Otherwise, on behalf of our country project director, Dr. Kusundinda, I'd like to welcome each and every one of you to this talk. Thank you very much. Back to you, Dr. Gitao.
Asante, Dr. Collins Jaguga. So right next, I will dive to our speaker for the day. His name is Dr. Kenneth Kariuki Irungu. He's a clinical pharmacist in Karatina Sub-County Hospital. For those who understand Karatina, it originated from the name quarantine. And just an offside comment is quarantine. Karatina was a place where cattle was quarantined against anthrax. So that is the name. The Kikuyus are not able to pronounce it. They said Karatina Sub-County Hospital. Dr. Kenneth Kariuki Irungu is a clinical pharmacist stationed in Nyeri County, Karatina Sub-County, and he's currently the secretary for the Antimicrobial Stewardship and the MTC committees in Nyeri County. He's passionate about rational use of drugs and effective pharmaceutical care of the patient. He also has interest in research and HIV work. This he presented in last year's conference, that was the physical conference in Mombasa at the PSK annual symposium. So without further much ado, I will now welcome Dr. Kenneth Irungu to give us his words and insightful presentation. Dr. Ari, over to you.
Okay, so thank you so much, Dr. Mbao, for that glowing tribute and those good remarks. So just to assure you, we're not talking about cows and anthrax here, but hopefully we will allay good information about AMS to this evening. So welcome everyone. Let me go through the presentation today. So my presentation is will be basically going through the recap of what was done in part 1, then talking about what has brought us today here, and maybe at the end we'll have questions. So as a recap of what was said last time was that there's the presenter talked about the overview of antimicrobial stewardship, the National Action Plan on Antimicrobial Resistance, and the framework and goals of antimicrobial stewardship. So just as a recap, and what will form the basis of our talk, it is so fundamental that you understand what antimicrobial stewardship is. So just as a summary, it is a set of coordinated strategies of efforts to measure and improve antimicrobial use, and in so doing, promote positive good health outcomes and minimize ADRs and health costs to the patient. So from last time, the presenter talked about the National Action Plan on Antimicrobial Resistance. It is based on 5 strategies. And the first one is public awareness and evaluation. So here we are talking about awareness to the public. This is mass media, talking about radio, television messages to encourage the populace to use antibiotics properly. And it also goes to the level of the health worker, whereby Dr. Collins mentioned about pre-service training and in-service training. So this AMS stewardship, use of antimicrobial, proper use by healthcare workers. So education, that's number one, to population and to healthcare workers. Number 2 strategy is surveillance and monitoring. This is just looking at the patterns of antimicrobial resistance. The bugs, the super bugs we have, we want to find out to what extent we have them in our hospitals. So we want to find out the which bugs do we have, which are the resistant one, to which extent are they resistant. Then we also want to find out how we are using antimicrobials. These are audits, these are point prevalence surveys, audits for outpatient and PPSs for inpatient. Then you have your infection prevention and control. This is the third strategy. You want to control those superbugs, so to say, not even the superbugs per se, but even any infection. You don't want to get sick. The best way is prevention. So here you have your hand wash campaigns. You have your environmental hygiene. You have your waste disposal, proper waste disposal mechanism. Then number 4, the fourth strategy is appropriate use of antimicrobials. As healthcare workers, this is where most of us will be rotating along. Our work will be revolving around here. Appropriate use of antimicrobials. We may have clinicians here. So how do you prescribe? Is it based on guidelines? Is it rational? You have dispensers, you have pharmacists, pharm techs, you have nurses. So how are you using your antimicrobials? This cuts across current times. You're talking about One Health, and One Health approach talks about human health, livestock, agriculture, and even fisheries. So One Health aims to coordinate all these departments to ensure that antimicrobials are used properly, not only in humans, even in animals, and even in agriculture, so that you don't get antimicrobial resistance. Then the fifth strategy is research and development. This transcends all the other strategies, because research and development is somewhere we are talking about funds. This is at, let's say, national level, partnerships with people like USAID and other partners, whereby they will plug into the funds. They want plugging into the system funds for evaluating the antimicrobial patterns, supporting lab facilities, improving diagnosis, how we diagnose, and basically even up to the level of development of new drugs, if that is the maximum point you will reach. So the framework for antimicrobial stewardship from the last presentation has the 3 pillars. Development. This is development of new antimicrobials, development of new diagnostics. And once you develop, or you have already what is developed, like the current status, your drugs, your lab tests, how accessible are they? That's the second pillar of the framework. How accessible are the drugs? Are we saying we have first line, second line, third drugs, and you don't have access to first line or second line, you're going to the third line? how accessible are all those first, second, or third line. In other terms, WHO terms, you call them access, watch, and reserve categories. So how accessible are those drugs? Then, very importantly, you have access to these drugs. How are we using them? How are we conserving their use for future generations? Not only even just to the patients at hand, even yourself as a healthcare giver. How are you conserving it? Because you might be the patient next time. So this conserving is now what we're talking about, stewardship, not just blanket access, is just conserving and trying to make use of what we have. That's the stewardship pillar for the framework. So what are we trying to aim with this antimicrobial stewardship? You want to improve patient outcomes by reducing infection rates. You want to improve patient safety, because when you do stewardship, you'll prevent readmissions because of you'll be able to manage illnesses, so you prevent readmissions. You even be able to prevent ADRs because you'll be using what is in commonplace. You'll be looking at not just this person said that is reacting to this drug. You, from AMS perspective, you're able to curtail use of drugs that are potentially toxic to patients. Then AMS, another aim, another result is what you are trying to do. You want to reduce antimicrobial resistance. You're conserving what we have. You want to use evidence-based, not blanket use of medication, irrational. So you're targeted therapy based on susceptibility patterns, antibiograms present. So in so doing, you reduce antimicrobial resistance. Overall, you end up reducing healthcare costs. You don't use superior third-line medications. You don't waste money for the patient. So you end up reducing healthcare costs for the patients and even the whole healthcare system. So on to our talk for today. Today we are going to talk about the components of antimicrobial stewardship programs. So these components fit within that national antimicrobial national action plan on antimicrobial resistance. So when I talk about them, you'll find them in your minds clicking into place among those strategies. And so just to contextualize, we've talked about AMS as a set of coordinated efforts. So these coordinated efforts, by the end of the talk, I'm trying to put in our minds that these efforts, these components are not just at your level as a healthcare provider, you and your patient, at the community pharmacy or even at the hospital level or the clinic level. These components start all the way from a broader perspective, higher than you are wherever you are. So they start from research and development and have other two levels before you get to your level as your end users, or also to say ground level, you as healthcare provider with your patient. So the objectives of this talk are to describe the components of an AMS framework, then describe the connection between these components, then outline for each component the gaps, the strategies, and leadership levels, responsibilities among each component, then apply the knowledge in diagnostic, prescribing, dispensing, and responsible use of antimicrobials. This diagnostic, prescribing, and dispensing and responsible use is actually a component of AMS, and you will see as we go forward. So the outline is similar to what is in the objective. So an overview of the AMS components. So, what factors influence appropriate use of antimicrobial agents? Maybe you can think on that for a minute. What makes people use antimicrobials the way they use them? So, the components of an AMS implementation framework. I've told you that you're not thinking this from the level of your diagnostics and prescriber level or dispensing level. This set of coordinated efforts to measure and improve antimicrobial use actually start from the point of research and development. So the components of AMS implementation are actually research and development. You have your regulation and manufacturing. Then you have your selection, procurement, supply chain, and distribution. That is your supply chain. Then you have now the ground level, the diagnostics, the prescribing, dispensing, and responsible use by the patient. The WHO, when it envisions the universal healthcare, it looks at all these principles and it tries to enhance each of these components. So you find that when you're talking about research and development, you find WHO has a stake on trying to monitor your resistant bugs and giving them priority areas. You find your WHO will think about development of vaccines for infection prevention and control. So this should trickle down up to our level as a country and even up to our level as county hospitals, even private clinics. So the first component, which is research and development, I've briefly alluded to it. So research is into the development of new antimicrobial diagnostic tools, vaccines, and interventions for preventing and controlling AMR. You find systematic reviews like already done, like currently those one done by S. Omulo et al. In 2015 showed that the pipeline is drying out. The pipeline is drying out. There's improper use of already what we have. Patients are self-medicating. So we are not conserving what we have. So from the point of research and development, I've told you, we are thinking it above our level. We are thinking from a perspective of pharmaceutical industries, evidence-based. So they are at what is currently happening. We are getting new bugs. We are getting new super bacteria resistant to penicillins, extended spectrum, beta-lactamases. So are we getting new antimicrobials to this? So there's a strong push towards development of new antimicrobials. Then diagnostic tools. There's some thoughts that empirical evidence is what trends. The people don't use diagnostic tools. There are no lab tests being done. So if the lab tests are being done, the current ones have a long turnaround time. So a clinician or even you at the community pharmacy or your clinic, you tend to belittle the lab evidence. So you just go straight ahead. So there's a push towards new diagnostic tools. Let's say even for TB, for example, the test for a bedside test for determining TB infection. So it's called urinary lamp. So there are new diagnostic tools underway. Vaccines to prevent infection. We're talking of COVID-19 currently. Even for other microorganisms, vaccines are underway. Then interventions for controlling AMR in whatever setting, maybe in a hospital setting. We're talking of restrictions. We're talking of pre-authorization forms, aware categorization, such things. So if you have a good research and development arm in AMS program, you're able to actually support access and stewardship. You can make a case for new antibiotics in your facility. You say you have a prevalent presence of let's say Pseudomonas aeruginosa, Cinetobacter baumannii. You as a pharmacist or a clinician with such data, you can actually present to your funders and say, this is what works for this bag, and you're able to get support for those those antibiotics. So in line with this research and development, I said WHO has put priority among research for some pathogens, and currently there are 12 priority pathogens, and there are critical priority and high priority and medium priority for research and development of new antibiotics. So as a critical priority, you have your Cinetobacter baumannii, your Pseudomonas enterobacteria. These are resistant to carbapenem. So really a big menace if you ICU patients, for patients who are staying in hospital for long, you know, so common infections. So, and very resistant to nearly every antibiotic you could think of. So that's a critical priority area for research. Even your high priority, you have your Enterococcus faecium. Then you have your Staph aureus resistant to methicillin, and even currently your vancomycin. You have your H. pylori. Everybody has a H. pylori test turning positive, being given clarithromycin. You get clarithromycin resistant. Fluoroquinolone resistant bugs, your Campylobacter, your Salmonella, going to the level of even outbreaks with Salmonella, and you find all your typhoid have, or a large percentage of your typhoid is due to fluoroquinolone resistant Salmonella. You have your Neisseria gonorrhea, developed resistant from all the 1970s up to now. Started with tetracycline resistant, up to now we are almost cephalosporin resistant. And such bugs have developed, like Neisseria gonorrhea has nearly all your systems, all your mechanisms of developing resistance. So sooner than later, it might actually go to critical priority. Then you have your medium priority bugs for research into new antibiotics. You have your strep pneumo for your pharyngitis. Nowadays, you hear people talking about my pharyngitis, or so to say your tonsillitis is not responding to your penicillin. So many people working with the IV lines for cephalosporin. It's a big problem. Your H influenza, your meningitis, nowadays you can't think of a penicillin to treat it. So cephalosporin. Shigella is also resistant to fluoroquinolone. Yeah, so those are priority areas for research and development as been assigned by WHO. So challenges in this research and development component. Data from surveillance on antimicrobial resistance and transmission dynamics is a challenge. For us, most of us who are here, human health already is a problem. We don't have data for our antimicrobial resistant patterns in our hospital, to say like in our government hospital, like in Karatina. It's very difficult to get a microscopic culture and sensitivity pattern for any bug you could be thinking of. But fortunately, in the larger facility, we are getting support from the national office, a partner called IDDS, and they are working on an antibiogram. So such measures like this replicated across the country may be beneficial in pointing out these patterns on antimicrobial resistance. So that is just on human health. When you go to livestock and agriculture and fisheries. That's another whole can of worms, because, for example, in Karatina, there's a regional vet laboratory that is supposed to monitor for resistance for what was previously called Eastern Province. So it covers counties from all the way from Marsabit, Moyale, up to Kitui. So you can wonder the efficiency of such a lab. So because this lab is supposed to measure for resistance from samples from milk, from animal produce, from fish, and dealing with samples from such a broad aspect is a very big challenge. This lab, the regional vet lab, is supposed also to check for antimicrobial levels in foodstuff, in milk, in meat, in eggs. And being so overwhelmed, you can imagine what will happen. We'll end up with, so to say, food that is not supposed to be fit for human consumption, because we are actually taking antimicrobials unknowingly through our food produce. So this is a big gap, and maybe a leadership challenge for anybody who might be listening. Then we have infection prevention and control implementation program. How are our IPC measures? I know something like hand audits, hand wash audits, or hand hygiene audits are not commonplace in our facilities, though we try maybe once in a while, but how much are we doing it? But in the COVID-19 era, we have seen this trying to improve. But you see, still have other challenges with PPEs, environmental hygiene. So IPC is a challenge. New vaccines, it's also a problem. So infection prevention along that line, we are making some headway, but still a challenge. Lack of access to point of care diagnostics in our facilities, maybe in government. Even full hemogram might be a challenge. Lab capacity is limited. If you even have the lab capacity, the challenge again is the turnaround time. So before even you get the result, you may find you already requiring to use an antibiotic, and this is a big problem. Maybe research and development may be able to address this, and the partners there, Nacosti, Cambridge, and maybe it's a factor that will be addressed at the national level. So preclinical research for development of new antimicrobials, you find that local manufacturers depend on what is already in the Western market, and the R&D departments are not so functional. Then tertiary learning institutions, we generate a lot of graduates with a lot of information. Let's say pharmacy, you have a lot of pharmaceutical analysis knowledge, you have a lot of pharmacology and receptor knowledge, but how applicable is this? Maybe we may have to reach a level of just having some basic microbiologic information that can assist us in developing some drugs or some interventions that can be able to develop or work around the resistance of the bugs that you're already seeing. So the second component is regulation and manufacturing. So regulation and manufacturing, we have the regulators. You have your PPB, you have National Environment Management Authority, the professional bodies, that's a PSK, you have your Association of Clinical Officers, nurses, you even have your Kenya Medical Association. So these bodies, they're supposed to be enforcing what is happening. How are you prescribing? We're not just saying that you've done enough to monitor. you've not done enough to ensure somebody is the environment is okay. But how much supervision are you giving in that private chemist, in that community pharmacy, in that private clinic? And even to add on to that, how much are these regulators doing to ensure the people working in these healthcare facilities are licensed and qualified? So if you had a good regulator, you'd see the following rules. You'd be finding you have good prescribing, good dispensing, and overall good use of antimicrobials. You'd find that you have good production and importation of high quality antimicrobials. Still, I'll quote the study done by Esomulo et al. 2015. They found that there's an extensive market. In this market, there's extensive prevalence of counterfeits and substandard medication. So goes back to the regulator and the professional bodies. They also looked at the capacity of the people providing the services. So this goes back to the regulator. So if you also had a good regulator, you would be able to control the emission, the environmental emission of antimicrobials. You will be able to, the industries won't be giving effluent to the pharmaceutical effluent to the environment. In our setting, community pharmacy, or even your hospital, waste disposal, your pharmaceutical disposal, it will be up to par. So challenges with this component of regulation and manufacturing is weak regulation of community pharmacies, even weak regulation of private clinics and private healthcare facilities generally. We may be doing so much in our public hospitals, in our big facilities, private facilities, but what is happening in your neighborhood clinic? What is happening in your neighborhood community pharmacy? It's a big challenge. We present on AMS to our facilities, to other healthcare workers, and they always ask that question. We can do all this, but what is happening out there? So they get discouraged, but we always tell them that that is work for the regulator, and we know MTAPS is roping in all those regulators to support this, so that we get more inspections and even more empowerment to do AMS through education, through even restriction, and working with our professional bodies. Yeah, and even some intense incentives like NHIF support to those who will implement AMS. So also for regulation and manufacturing, another challenge is weak surveillance of antimicrobial use. So you find that in our setting, there's no proper way of measuring how we are using antimicrobials. You see that we can do the audits, but on an outpatient audits for antimicrobial use, or a point prevalence service for inpatient, but that will only suffice for your hospital. What is happening in the broader sense? There's the thought of trying to leverage on the current systems like DHIS, the LMIS, to be able to measure the antimicrobials, and in so doing, you'll be able to put in interventions and be able to improve on this, and even leveraging on things like the donor programs for HIV and TB. This will be able to improve the surveillance on antimicrobials. You have the weak regulation of pharmaceutical waste management as a challenge. So I alluded to it. You find that some policies might be crippling, such that even disposal of medical waste is a challenge, or even pharmaceutical drugs is a challenge, so that some people may just end up disposing in a haphazard fashion. They would be skeptical to look for the regulatory demands, your F458s, your procurement approvals, all those, and just dispose randomly. So you get a challenge with that. And even if it is there, there's no enforcement of that policy of waste disposal by either even the waste disposal teams or even NEMA. So the third component of the AMS, a good AMS program, is a good supply chain. And by supply chain, we mean selection, procurement, supply, and distribution of drugs. And a supply chain is a network of individuals, organization, activities, and resources and technologies involved in the delivery of a product from source to recipient, institution, even up to recipient of the patient. So a good supply chain will be able to ensure you have disease control. This is up to individual patient level, because you're talking about a patient. So if a patient is able to get the right drug for the right indication, you're able to control that disease in that patient. So that patient won't keep coming back to the hospital. And in the level of public health sense, in the sense that if it's pneumonia or diarrhea, and it's a communicable disease, you'll be able to contain it. If you're able to treat the specific number of people with the right antibiotic, other people won't get that infection. So a good supply chain would curb and promote disease control. A good supply chain will will ensure proper antibiotic use. You have your aware classification. So if you have a good supply chain, you have all your antibiotics right from access, which for a colloquial term would say is your first line, and you have your watch category, which is your second line, then your reserve category, which is your salvage medication, or your third reserve, without having first used your access antibiotics. So the other thing with the good supply chain, you ensure you don't have counterfeit medications, because a good supply chain will ensure that you're sourcing from the right sources. You don't have stopgap measures running around to get drugs from unscrupulous sources. So a good supply chain will ensure you have the right drugs that are not counterfeits or substandard. So just to add on, selection in the supply chain should be guided by evidence. So you have your evidence based, you have your research, you have what is currently working, not what worked 10 years ago. So if you have a good supply chain, you have your evidence, and this evidence, you're able to select and come up with the right essential medicine list for your facility, for your clinic, for your community pharmacy. So that is your selection. So you have a good supply chain. And the other aspect is you have good procurement. So you have good procurement, you have uninterrupted supply. You won't be having shortages, you're out of stocks, your expiries, your losses. So you end up having you end up having not to run around or giving what is not your first line or second line or your third line, or using your first line as your second line. So if you have a good procurement, you have an efficient flow, a continuous flow, a pipeline that is efficient. You don't have shortages and you don't have wastes. To ensure this, you can have a proper forecasting and a proper validation of where your drugs are coming from. A sustainable source, a source that is reliable. Your other component for supply chain is your supply and distribution. So your supply and distribution, you're talking of movement of the antimicrobials from the source to your health facility. This is, you're thinking of something from the warehouse, for example, for us in government facilities, KEMSA, how you're sourcing it, your paperwork, how it's going to be transported, is it efficient? Are the integrity of how it was stored in the warehouse, the integrity of how it is being transported, and the integrity of how you're receiving it. Is it secure? Is the whole movement secure? Are your drugs safe? So a breakdown in any of those logistical measures will lead you to having substandard drugs. And these substandard drugs again lead you to AMR resistance. And you end up having an extra cost and opportunity cost of poor health outcomes. So the best practice is you ensure you get the right medicine available to the right patient at the right time and at the right price. A good supply chain, trust me, it will make sure you get the drugs at the right price. So the challenges of having a proper supply chain is that we are talking about evidence-based modalities, evidence-based treatment. And what you see is that like the national pharmaceutical policy, the last draft was in 2008. And this is what guides how drugs are sourced and even procured and gotten up to the level of the patient. So you can imagine we use a document that is currently 12 years old. So that is a problem. Then you get formularies. At the last formulary based on the standard treatment guidelines. Fortunately, the essential medicine list has always been evolving, but the standard treatment, the national standard treatment guidelines, the last ones were in 2010, I think. And if you're in the current era of evidence-based medicine, some of those things that are in those guidelines are obsolete. So, but fortunately, I think support from MTAPs, I think there's a new national treatment guidelines that was to be launched either last year or this year. So, but the other fortunate thing we've gone around this gap is that there's people are using international standards, so international guidelines, and in a way it has assisted in trying to curb the selection of improper medications and antibiotics. And even we have our vibrant MTCs in our facilities, like let's say Karatina or Nyeri County, all of them have vibrant MTCs, and there's always that drive to source for publications and new data. So another challenge for supply chain is weak communication channels. So for example, you find in MTCs, in let's say the government sector, I'll still use that example. KEMSA, you get, if you're trying to source for a drug and something along the way you did an error or you forgot, or KEMSA did an error, and you trying to sort out that mix of errors and movement and rectification is a very big problem. We have the liaison officers, but there's a weakness in that communication channel. Then also the MTCs who try to aid in selection of the antimicrobials to use in a facility, they then also may be having a problem trying to meet up and establish that rapport with the suppliers. So you have inadequate competencies in procurement. It is unfortunate that in our facility, in our public health facilities, there's we are not solely the ones as clinicians or pharmaceutical personnel who are involved sourcing for these drugs. You just place your requisition, it goes to procurement, it goes to the supplier, it goes to, so there's a challenge along that chain of people to assist in sourcing. There might be a problem in the training. Then we have this bureaucratic, challenge, bottlenecks, like if means you have to fill some certain documentation, and this may be a problem. We are also restricted to drugs that only in the KML, and this is also a problem for us when we are thinking about our supply chain and getting the right drug to the right patient at the right cost, the right indication. So our last component is the diagnostic, prescribing, dispensing, and responsible use of antimicrobials. So here now is maybe what I would think about as the ground level, things on the ground. What is happening? What are the diagnostics? How do you arrive at a good diagnosis? How do you ensure that it's the right drug that has been prescribed? How do you ensure it is the right drug that has been dispensed? If it's the right one, how is it being used by that patient? Is it responsible use? You find that for an accurate diagnosis, they talk of having good history, good examination, and to back that up, you have a well-directed lab investigation that will give you the identity of that pathogen that you are thinking of. And on top of giving you the right pathogen, it will give you even a susceptibility to that pathogen. So if thinking along that line, you're able to have a good stewardship of antimicrobials. So if you are able to be able to have that line of good history, good examination as a clinician, even as a community pharmacist, or even as a community pharmacy personnel, or even any practitioner in the healthcare field, that is the line that should be followed. A good history, a good exam, a well-targeted, directed lab investigation, and preferably, if you can, a susceptibility pattern for the pathogen. So if you're able to follow that, you can get good results as curbing antimicrobial overuse. You prevent over-reliance on empirical prescribing. Actually, empirical prescribing has been termed as the death of antimicrobial stewardship, but that is something maybe for debate. And also the good diagnostic up to responsible use will be able to curb poor outcomes from treatment failure. If you follow that line, which I've described, you're able to review empiric treatment, and in so doing, You can escalate treatment if the treatment is not working. You can de-escalate to narrower therapeutics, narrower drugs. You may even have to discontinue a medication if it wasn't indicated in the first place. We had mentioned about standard treatment guidelines. This would, if they were up to date, this would facilitate in a very great way this flow of getting to diagnose and treat and dispense patients well. So diagnostic stewardship is just what I've just said. Trying to get a good history, trying to examine if you can. We're all healthcare workers here. So I think a history and an exam should not be a challenge to anyone, even a simple exam to what you're thinking about. And a targeted lab investigation is also shouldn't be a challenge. So those things, history, exam, lab investigation, culture and sensitivity, if you can, that's what we're talking about when you talk of diagnostic stewardship. And your investigation, and you shouldn't be timely so that you facilitate a good positive outcome and prevent what empiric treatment may cause. That is blanket treatment for everyone with certain antibiotics. So this is what I'm talking about, history, the diagnostics aspect, healthcare workers, your history, your exam, that's a large percent of your, what will consist to your coming up with an accurate diagnosis. Then your lab support, which should be timely and accurate. And this lab support should be preferably at the point of care, so that you don't have to wait for so long to determine what is ailing this patient. Then these diagnostics can be evaluated by having good support supervision. Some of us are managers, so you can support supervise from level 5 downwards up to your community health unit, your level 4, 3, 2 health centers, dispensaries, trickle it all the way to that neighborhood clinic, that neighborhood community pharmacy. What are they doing? Support supervision would be able to ensure good diagnostics are being done in all these facilities. So you do that. You do the diagnostics. You have that fundamental basis of coming out with your diagnosis. Now you're going to prescribe. You as a clinician or a healthcare worker, or wherever you are, because I'm addressing many people here. So you are there. You are at the level of prescribing now. What will guide you to make you give an informed choice? Look at the right side of the slide. The right side of the slide has 5 aspects that maybe you, wherever you are, as a clinician, as a healthcare provider, as a pharmacy personnel, what do you look at when you want to prescribe? The first one is severity. This is looking at how severe your patient is. Is your patient stable? Is your patient unstable? Do you need to give oral medication, or is it do you need parenteral? Some cases you may need to jump from first, second, all the way, or not from access all the way to watch category of antimicrobial. For example, you find a patient with sepsis without just sepsis, has all the symptoms of, let's say, septic shock. For such a patient, you may just have to go to your watch antimicrobial. It is not severe patient, unstable patient, you may just have to do with oral antimicrobials. Then the source of your infection. So what is the source of your infection? Patient may come with the complaints of dysuria, frequency of urination. Then the complaints may fit a UTI. So it is up to you. You are thinking, is it a lower urinary tract infection? Is it a cystitis? Is it an upper urinary tract infection? What you call your pyelonephritis. So you have those three. You treat them differently when it comes to your prescription. And you look at your differentials, the source. Or before the differentials, look at the source. If it is, let's say, your UTI again, as an example, what particular bug do you think is causing this UTI? If it is UTI, it's most likely it's a gram-negative bacteria. So you wouldn't want to go to broad spectrum or even something that is targeted to gram-negative. If it is, let's say, your respiratory tract infection, you're thinking it's a gram-positive. So your source is crucial. Then again, when you're looking at your source, you're looking at your differentials. Is it really an infection? Is it let's say, renal stones and not a UTI? Is it an STI with referred pain, or is it a fungal infection? So you need to think about this when prescribing. Then drug resistance, you're thinking, has this patient taken any other drugs before? If they've taken, have they responded? You want to think of such things. What is your antimicrobial susceptibility pattern in your facility? Are the patterns so high, showing that the infections in this facility are, all of them are due to resistant bacteria? So drug resistance, think about that. Patient factors, when you're prescribing, look at the patient. Is the patient metabolizing well? Do they have ascites? Do they have renal complication, liver complications? Are they pregnant? Do they have allergies? So these are things will guide you in prescribing. Then cultures. You may have to wait for cultures for some patients. If they are stable, you look at, this patient has received these antibiotics for the last several months. This is a patient usually you need to do a culture before treating. So the principles of antimicrobial prescribing, it's an acronym. Mind me, you look at the microbiology wherever possible, the results. Then you look at the indications, should be evidence-based. Narrowest spectrum, preferable, use the narrowest spectrum. The dosage should be appropriate to the site and type of infection. So you may see, like, if you want to penetrate a certain level of the body, let's say the blood-brain barrier, you may have to use a higher dose. And also, when you're talking about the type of infection, okay, at some levels you may have actually to use maybe a higher dosage than what is what you'd use normally. Then you minimize duration of therapy. This will curb AMR resistance, but for some levels, it's you can assess if the patient is not improving. But this is a really sick critical patient. Some duration you may have to increase based on that. A really sick patient, maybe in an ICU facility, you may find having a longer duration of therapy. And then you ensure monotherapy in most cases, because mostly you're targeting your one bacteria. So these other drug will just be causing or developing resistance in that case. So the last thing is dispensing and responsible use. So when you want good dispensing, you review the prescription. You check for the right antimicrobial. Is it for the right indication, the right patient? Is it being given at the right time? Is it at the right dose and the right duration and route? Curtail this and you curtail antimicrobial resistance. When you are dispensing again, you find that you will get a chance to do good medication use counseling. And when you do this good medication counseling, you emphasize to the patient the good responsible use of drugs, sticking to adherence, not stopping the medication when they feel better, finish the dose, not to self-medicate, that you felt better, then use it. They use it when they feel similar symptoms next time. It could be viral infection. So medication use counseling is an opportunity to do this. Then your medication use counseling will also help you to educate on good handling of the drug and storage. And essentially, even at the end of whatever, let's say, an excess dose, how to dispose that medication so that you don't get contamination or even reach of these drugs to even livestock or even to children or to other people in the environment. Or something that I forgot is that under the One Health approach, the infection prevention measures extend to the level of preventing infection to the animals, to the fish, so you find that that even vaccines are being developed for animals, for fish, because it has been found that even a resistant bug can cross over from an animal to human beings. So in such sense, you curtail or restrict medication use and ensure proper medication use for a patient, and it will influence all the way up to even how they deal with the with other things, like even their animals. So so you're providing education to the patient on antimicrobials and discouraging haphazard use of antimicrobials even for managing of viral infections. So just as a recap, the components of AMS. AMS is a set of coordinated efforts or strategies to curb, to measure and improve antimicrobials, to curb resistance and improve patient outcomes, and reduce healthcare costs and adverse drug reaction. Those components are outlined in a larger sense in the National Action Plan. And those components, when you break them down, they're essentially 4, and move from research and development to regulation and manufacturing, good supply chain, and essentially good diagnostic, dispensing, prescribing, and responsible use by the patient. So maybe as a point of reflection, you can see this quiz. First question is, lab investigation is mandatory in order to obtain accurate diagnosis of infectious disease. Is this true or false? Maybe you can marinate on that one. Then second question is, choice of antimicrobial with the narrowest spectrum required is one of the principles of prescribing antimicrobials. Yeah, true or false? I leave you with that, together with what we've presented on the talk. Just think about it and see what you can do as a healthcare worker to ensure we have good antimicrobial stewardship, whatever level of care you are in patient care. So thank you. Those are my references. Any questions? So I hand it over to Dr. Mbao.
Asante sana, Dr. Kenneth Irungu, for your insightful. It has been a class. I have followed slide after slide. And before I water it down, I want to call in Dr. Collins Jakuga, who's going to guide through the question and answer section. I'm even seeing my lecturer is here with me, Dr. Edith Okori. Asante sana, Daktari, for joining us this evening. Dr. Collins Jakuga, kindly take us through the Q&A section.
Good evening once again, and thank you very much, Dr. Irungu, for the very comprehensive and enlightening talk. Yes, we do have a couple of questions this evening. I'll start with 2 questions by Dr. Ogaja. Thank you. One is how widely disseminated is the National Antimicrobial Strategy to the general public? How widely disseminated is the National Action Plan on AMR to the general public? You want to respond to that, Dr. Irungu, before I read the next?
Okay, so thank you so much. That's a question from my senior, so much appreciated. So this question about National Antimicrobial Strategy and dissemination to the general public. So I can't really say that it has been measured. I can't have a direct answer to that, to say that this is how much dissemination has been done in the public, in the general public. But what I can say is that it's something ongoing. For example, like in Nyeri County, we have had continuous sensitization. Number one, to the healthcare workers. You have health talks to the patients when they are awaiting treatment in the various departments. Then at a higher level, we have the county. It's called County Antimicrobial Stewardship Interagency Committee. This is made up of the departments of health, agriculture, livestock, and fisheries. So this CASIC has gone to the extent of having talk shows in vernacular in the radio stations, and it has issued out even messages through bulk SMSs, because we were a pilot county for UHC. So the bulk SMSing system, they have added messages to that messages they send to the general population on health. They've added that part of antimicrobial stewardship. So I can't really quantify how much dissemination has been done, but maybe as a surrogate, that is what I can say. Thank you.
Thank you very much, Dr. Irungu. And sorry, I forgot to mention that with Dr. Irungu and myself in the list of panelists is Dr. Joseph Mukoko, Principal Technical Advisor, USAID MTAPS program. So he'll be at liberty as well to comment. And just to add on to what Dr. Kariuki Irungu has said, I do not think the National Action Plan on AMR has been disseminated to the general public. I believe the dissemination has targeted healthcare professionals, animal health folks, agriculture folks, and the environment guys. However, there are efforts here and there, and especially in healthcare facilities, to sensitize the public on appropriate use of antimicrobials and the effects of AMR. The second question, again, still by Dr. Gaja. She does say that there's already a policy in place, the sessional paper number 4 on the Kenya National Pharmaceutical Policy that was passed by the 9th Parliament, and it dealt extensively with the issue of antimicrobial resistance. There unfortunately does not seem to be political will to implement it. What new approaches could be brought into play to have the ministry create structures for implementation instead of starting again to create new policies. I don't know whether Dr. Mukoko, you want to respond to this?
Yeah, thank you, Dr. Gaja, for the question. I know this is one of those areas where we are always looking at what has not been done, but I think one of the key things is always to also look in terms of what can we do. Moving some of this, there needs to be quite a lot of advocacy efforts because these are some of those areas where we really need to convince others so that we can be able to move the agenda to the next level. I know there are efforts to even review some of the kind of pharmaceutical management strategies. We need to be able to step back and look at what has worked, what hasn't worked, so that we don't continue propagating what we know is not going to give us the results or move forward. The other thing that we also need to look at is, of course, trying to harmonize the way we deliver some of the services, try to also enhance the professionalism within the sector so that somebody can also then be able to identify services that are being offered by a professional compared to somebody who is not a professional. Otherwise, it becomes a challenge if even the professional cannot be able to distinguish what they are doing from the non-professional. So it's not something I will say I have one straight answer, but we need to look kind of in a holistic way and kind of identify some of the low-lying fruits. Of course, I know the ministry is also trying to see how it can advance this to improve the quality of pharmaceutical services. I know PSK, the professional associations, there is what they are also looking at. Across the health professionals, they are also looking in terms of how this can also be enhanced. So it's one of those that we really need to kind of step back and look in terms of how can we enhance, number one, the quality, the advocacy efforts, and also just trying to demonstrate the value addition that can be accrued by focusing on improving some of these areas. So I think that's what I can say, unless somebody else has an additional comment.
Okay, thank you very much, Dr. Mukoko. Dr. Irungu, any contribution before we proceed on?
Okay, I've seen maybe these are the upcoming professionals who are maybe even at the higher office. We've seen there's a change among them. So I don't know, maybe you can continue just giving pressure to them so that they might be able to lobby for us wherever anybody can lobby. This can make a big difference. Thank you.
Okay, thank you very much. Bagwat Diwedi has a question here. Are there practical lab-based training on antimicrobial resistance research to tertiary level students?
Okay.
Not that I'm aware of.
Even me, I'm not sure. I don't think there's any currently. But I think we saw it as a challenge. We saw it as a key challenge among in the component of research and development. So it has been proposed in that presentation, and also I think in the National Action Plan for Antimicrobial Resistance, there's the surveillance. There's a surveillance. The surveillance strategy. So that surveillance strategy tends to surveillance strategy as well as the research and development strategy. So I think it serves to address this question. Maybe in the future. Maybe in the future, it's going to be there. Yeah.
Thank you. Then Dr. Ben Ogonji has both a comment and a question. So his comment is that the pharmacist is the drug expert. So once the diagnosis has been made, ask the pharmacist for the best drug, the best medication. Thank you for that comment. And then your question is it possible to decentralize inspection? I believe inspection of medicines or healthcare products and technologies in general. Dr. Mkoko, having worked at the Pharmacy and Prisons Board, I believe you're in a position to respond to this. Is it possible to decentralize the inspection of health products and technologies in Kenya?
I think it's possible, and I know PPB, they have quite a lot of personnel out there. I'm not sure whether we have any representative who is attending so that they can just be able to, but the short answer is yes.
Great.
The modality could be different, but I think definitely it is possible.
Okay. Finally, Dr. Stephen Kimatu, and thank you for joining us all the way from Washington, D.C. Dr. Kimatu's question is that the presenter indicated that according to Omulo et al., there is a high number of substandard stroke falsified antimicrobial agents in the Kenyan market, which may be leading to AMR. However, based on the post-marketing surveillance reports undertaken by PPB, these show different results. For example, since 2010, the PMS surveys on antimalarials show less than 5% failed quality. How comes we have such a difference on the quality of antimicrobial agents and antimalarials in the same market? Dr. Irungu, Dr. Mkoko, any of you could go first.
Oh, so the other thing about the S. Omulo study, they did the study in East Africa, but the results are extrapolated to everyone among the East African countries. Then the other thing is the National Action Plan on AMR also details the same. There's just to quote it, NAP has said some AMR is attributed to substandard and counterfeit antimicrobials. Just a snippet that they have said that some of the AMR is attributed to substandard and counterfeit antimicrobials. So for them, they're saying regulation is the problem. There's a part of blame that could be attributed to regulation. So Dr. Kimatu, I don't know, he's contradicting this. So maybe further information may be warranted. But that is what I gathered from the National Action Plan and the study by Omulo et al. In 2015.
Maybe I can also just add to the comment. If you look at PMS, the post-marketing surveillance is a very costly activity. And most of the ones that are undertaken, you find they tend to focus on some of these program commodities. That's why you'll keep seeing a lot of the, malaria, TB, HIV, and such, because a lot of those are probably being funded through a donor. I think as we continue, what we need to start looking for is a holistic system that can then be able to kind of ensure we can be able to undertake the PMS for all products so that we can be able to then say with the, conclusion that, yes, when it comes to antibiotics or these other kind of products, this is how they vary. But a lot of it has to do with probably a funding issue. And no wonder you can see where studies have been done, either within the region or in other African countries, there's a tendency to then extrapolate some of those figures. Over.
Thank you very much, Dr. Mkoko. I can see one very last question. I think we still have 2 minutes or so by Kefa Mogere. Last year, but one, we raised an alarm over the mass uptake of IPT. I believe this is a isoniazid preventive therapy on HIV patients. This year we are struggling with INH monoresistance. I believe that is isoniazid monoresistance. Now the guidelines have come again on the use of RH. It should be rifampicin isoniazid. So the question is, do the policy makers take into consideration antimicrobial resistance? Do the policy makers take into consideration antimicrobial resistance?
Dr. Collins, maybe you would be more suited to take it up, but I think all this is evidence-based. Sometimes the evidence may be counterproductive, and those are usually the thoughts when they're thinking of introducing such measures. So I don't really know the evidence, whether you can counter it, but some of the evidence is just out there and is so plain, and it's just so we've talked about they look at the p-values, they look at the evidence, the results, how convincing it is, and the recommendation and the larger benefits of implementing a certain strategy. So, but I don't know. I think Dr. Collins may speak on it.
Well, thanks, Dr. Irungu. I'm not privy to the rationale behind the recommendation on the use of RH, given the previous history as raised by Kefa Mogere. So, to be honest, I'm not privy to this. Unless, I don't know, Dr. Mukoko, may you be in the know about this new
I think the best way where there are such concerns would actually be to basically, rather than propagating, the doubts, is just to get directly in touch with the program so that they can then be able to provide more information or kind of share their rationale. Because at times, we've always seen there's a big lag between the decision that is made and all that information, the rationale being disseminated to the frontline workers. So I think the best would be to just do your, if you have a write-up, then just quickly get in touch so that they can then provide. But if there's anybody at the national level, I think the best then would also be to also review if there's any information that is coming from the lower levels so that they can relate with whatever decisions they've made. So it's more of just to be proactive so that we can then be able to ensure we can get that information.
Great. It's now 8:30. Thank you very much, Dr. Irungu, once again. And as we come to the end of this webinar, I would like to request my colleague, Dr. Joseph Mukoko, just to give some closing remarks and officially bring this webinar to a close. Karibu, Dr. Mukoko.
Yeah, thank you, Collins, and thanks everyone for coming. I know this is an area that is increasingly opening up. Of course, we can see the circumstances under which we are now currently operating, where some of these challenges are now becoming live. As professionals, what is critical is to continue looking for these kind of opportunities and see how best we can translate this into our practice. As we continue, we'll keep, of course, working with the PSK and the other professional associations to be able to see how do we enhance the whole aspect of antimicrobial stewardship. And antimicrobial stewardship, one of the key things, of course, is always ensuring that we are also able to work with the other health professionals so that the understanding in terms of the use of antimicrobials is understood in the same way. As pharmacists, I'm sure this is an area where you can take lead in also educating a lot of the other healthcare providers on how we can then be able to ensure that we are working towards the same goal. But for us, we want to say asanteni sana, have a nice evening. I'm sure this is a discussion that we shall continue. Thank you.
Asante, Dr. Joseph. Asante sana, Dr. Collins Jokuga, for giving us the opportunity to host this wonderful and auspicious webinar. Asante sana for our host tonight, our presenter tonight, and speaker, Dr. Kenneth Irungu. I wish to call the meeting to a total close and say siku tupatane wakati mwingine majaliwa yake Mwenyezi Mungu. Guests can leave at pleasure. And please remember that each and every Thursday for the next 3 weeks, we are having webinars with KMA. And from the 18th to 24th of November, PSK is actively involved in the World Antimicrobial Resistance Week. Asanteni sana and all have a good night.